national training online academic program by the PHO chapter of India. So we thank our chairperson Banavali sir and Honorary Secretary Mans Kalra sir for giving this opportunity. So this month's academics, we thought we'll all over the country we are celebrating Childhood Cancer Awareness Month, but we thought we'll discuss inborn errors of immunity. And we have
the childhood cancer talk is coming very soon. That is, we have scheduled for 25th. So the announcement, but it's coming very soon.
Yeah. So as always, we invite national experts in the specific subtopics in pediatric hem-onc and try to make as much educative session as possible to the trainees as well as the junior faculty, and also share insights from expert faculty. So without much delay, let's start the session this month. So the session is planned with 3 didactic lectures followed by a panel discussion. So we have eminent faculty from around the country. Brief introduction of each of them. Most of them don't need any introduction. Professor Mukesh Desai sir, he's been in the field of hematology immunology for more than 4 decades, and he's having more than 70 publications, and we know the amount of work he's done. Welcome sir. We welcome Professor Amit Rawat sir. He's been my teacher at PJ Chandigarh, and he has more than 300 publications, and his core interest is in diagnostic algorithms for inborn errors of immunity. He serves as the secretary of Asia South Pacific Immunodeficiency Organization, and ISPID as well, the president of ISPID. Welcome, sir. We welcome Dr. Ambreen. She's a consultant in BMT at Bijaywadia Hospital for Children. We welcome Revati Raj ma'am. She's been a pioneer in BMT in our country right from the times when there was like beginning of transplants, and now publishing data of Indian evidence in BMT. Welcome, ma'am, and look forward to a lot of insights from you. Welcome, Dr. Ajita. She's a consultant at GKNM Hospital in Coimbatore. So without delay, we'll start off with the first session. Dr. Ambreen, to talk about the recognizing clinical patterns in inborn errors of immunity. Over to you, Ambreen.
Thank you, Dr. Vinay. I am going to try to do justice to talk on such a broad topic. Can everybody see my screen okay?
Yes, it's in slideshow mode. Yeah.
So I'm going to try and do justice to this very broad topic in 15 minutes, I'm hoping, and I'm hoping that I can come across with the messages I want to. So when we look at immunodeficiency and hematology oncology perspective, let's probably start with pediatric hematology. And when we are talking about pediatric hematology, I would want to start with the first parameter as red blood cells. I'm going to try and do this case-based so that the take-home message reaches across as to when to evaluate these children who you see in your outpatient, inpatient practice. So the first case is a full-term female child. She was born with 2.8 kg birth weight and needed NICU stay. In NICU, she was found to have a hemoglobin of 4, was given 3 PRBCs and discharged well. At 2 months follow-up, her HB was 4.3 grams with a retic of 0.08. Marrow was done at this point, which showed suppressed erythropoiesis according to the report, with the rest cell lines normal. Interestingly, the hematologist did do an LSSA at this point and had naive T cells which were normal. So the child was concluded to have pure red cell aplasia with the anemia, reticulocytopenia, and suppressed erythropoiesis. And an NGS was then said. The NGS picked up an ADA2 deficiency with a BUS. This is when the child was referred to us, and we did the child's ADA2 levels, which were low. Now, deficiency of ADA2 is sort of an evolving field even for a lot of us, But just to put it together, this is the picture is from one of the earliest papers on ADA2, which was published by Mutes at that time. And if you look at the immunological and hematological manifestations in ADA2 deficiency, it can range from anemia, neutropenia, pancytopenia to PRCA, and include splenomegaly, hepatomegaly, and lymphoedema. This is a very interesting paper by Pew, which has come up in JASI in 2020, where they've tried to understand how does this phenotype kind of correspond with residual ATA2 activity and the genotype. And they have concluded that vasculitis is usually associated with a higher residual ATA2 activity, so more likely that etanercept may work in these scenarios, versus pure red cell aplasia or marrow failure is a lower ADA2 activity, more associated with nonsense, insertion, deletion, frame shift mutation, and TNF alpha inhibition may not work in this kind of scenario. So it's not only important to pick up what is the cause, it's also important to understand pathophysiologically what is my treatment option here. Moving to the next spectrum. So if you look at red blood cells, we had another patient, 7-month-old, firstborn of a non-consanguineous mismarriage, who came to us with cough, cold, and progressive pallor. She was referred to a higher center locally because there was cross-match difficulty. And on admission there, her hemoglobin was 3.4, retic of 24%, bilirubin of 3.2 with DCT and ICT positive. So easy to conclude, this is autoimmune hemolytic anemia. She was given IVIG and PRBC and discharged. On discharge, her hemoglobin was 10.9 with a retic of 15%. She came back a week later with drop in hemoglobin and this time received methylpred and was evaluated. A lymphocyte subset, of course, showed a low naive CD4 and a naive CD8 associated with high CMV PCR copies, and a genetic report picked up a RAG1 deficiency. So what you're looking at here is a scenario where you have a severe combined immune deficiency with autoimmunity, so autoimmune hemolytic anemia, and CMV. And RAG is one of those severe combined immune deficiency genetic genotypes which can actually also present with autoimmunity. Now, this patient came to us pre-letermovir, so we treated her AIHA with steroids and rituximab, treated a CMV with ganciclovir initially, followed by foscarnet, and she underwent a match unrelated donor transplant and is doing well 1 year post-transplant. In terms of red cell, I've looked at pure red cell aplasia to autoimmune hemolytic anemia. So let's move on to platelets. Now, with platelet disorders, I think it's really important to get this one disorder correct or look for it, especially in patients where we should consider them. So these are two patients, same disease, one diagnosed early, one diagnosed later. We've got a 16-year-old boy who was first symptomatic at 7 days of life with diarrhea. At 14 months, he had bloody diarrhea. I couldn't find his CBC at that time point, so I don't know whether he was thrombocytopenic. But at 5.5 years, he was noted to have melena with low platelets. A marrow was done, was considered as ITP, and steroids were started. In a similar scenario, a 5-month-old, first symptomatic at day 30 of life because of reduced oral intake, was found to have thrombocytopenia, initially considered to be secondary to sepsis, but it persisted despite antibiotic and appropriate antibiotic cover. So marrow was done, which was cellular, so IVIG was given. So in both these aspects, ITP was what was considered as the diagnosis. And when the child was referred to a higher center, the first boy who presented first at 7 days of life got diagnosed at 14 years of age with Wiskott-Aldrich syndrome. The second child, when referred to a higher center, got diagnosed at 5 weeks of life with Wiskott-Aldrich syndrome. So when we are looking at ITP, it's important to think, is this only ITP? Doing NGS is much easier, yes. Cost is always an issue, yes. But Wiskott flow is relatively easy to do, is not very costly. So if you have a male child, PS is showing microplatelets, even though it's a cellular marrow, is there a history of infection? Should I consider Wiskott in this scenario and evaluate them for Wiskott? The difference here would be really the outcome, because the 14-year-old boy who came to us had already had established bronchiectasis. So though both have undergone a transplant and are doing well, one of them is with leftover organ damage and the other one is not. And that is where the diagnosis in time matters. Looking at thrombocytopenia from a different perspective. So we had a 6-month-old male child, third-degree consanguine miscarriage, presented at 5 months of age with ecchymosis. At that time, he had low platelets and a marrow showed megakaryocytes. So he was also considered as ITP, treated with IVIG, methylpred, and romiplastin, but no response. Now, if you look at his CBC with a platelet count of 2, and if you look at this rash, I would also think, is this Wiskott-Aldrich syndrome here? But the consultant, the hematologist looking after, decided to do a lymphocyte subset and found very low naive and very low naive CD4 and CD8. And what we picked up is RAG again. So RAG1 phenotype of autoimmunity can have a huge spectrum. Any autoimmune cytopenia can have a huge spectrum of disorders which are also immunodeficient. Now, this child too, when he presented to us, he had a respiratory distress. He needed some kind of settling down before we went ahead with treating him. And we gave him rituximab too, and you can see the drastic response to rituximab in his platelet counts where they went from 2 to 190. And RAG1 deficiency, the genotype and the phenotype is primarily based on how much of recombination activity residual is there. So it can start from an impaired T cell and a B cell development leading to significant immunodeficiency and infection to also autoimmunity and immune dysregulation. So 2 aspects of how we look at platelets in terms of immunodeficiency. And let's look at neutrophils. This is a 3-month-old male child who presented with multiple episodes of fever, raised WBC and CRP with a normal umbilical cord fall. But interestingly, he had a sibling who had repeated infection, had a WBC count of 1 lakh, more than 1 lakh, and a flow was done for infant leukemia, which was negative. But by the time a diagnosis of LAD1 was thought in this child, it was too late. And versus with this present family history, this boy got diagnosed much earlier as LAD type 1. And honestly, in my opinion, whether it is leukocyte adhesion deficiency or severe combined immune deficiency, the spectrum of infections and the urgency of diagnosis, I would say is similar, because these are also patients who do not make it to transplant because of the amount of infections they get exposed to by the time the diagnosis is made. I'm not covering neutropenia because I think it's a huge topic in terms of immunodeficiencies with severe congenital neutropenia. And I'm also not going to cover lymphocytes because I think it needs a separate talk on its own. It's only important here for students to know that absolute lymphocyte count range for age group wise is really important to know, because that will help you understand when am I talking of lymphopenia and when should I evaluate this child further. Pancytopenia. Now, pancytopenia also can be secondary to immunodeficiencies, yes. But the spectrum now, with the amount of information that we have, makes it and be together at the same time. So we've got a 5.5-year-old boy who presented to us with multiple admissions since 9 months of age. His first admission was for bronchopneumonia. Here he's not needed transfusion, but then he's evolved into anemia followed by pancytopenia and has a hypocellular marrow. His 4th admission was for respiratory viral infection, and that's when he came to us. And an ALC here was low, so our hematology team looked him up for with a lymphocyte subset, and B cells was significantly low in number. He underwent a clinical exome and had MYSM1 as a cause for the marrow failure. Now, an immunological perspective of MYSM1 is that there's a block in B cell development and an NK cell defect. So despite the phenotype here being aplastic anemia, the questions were, why are they respiratory tract infection? Why are they respiratory viral infection? And one of them needed an ICU stay. So is this more than just an aplastic anemia and a pancytopenia picture? I'm going to take only one case of oncology because again, that's a really huge spectrum to cover, and in terms of learning also. So we've got a 9-year-old male presented with multiple respiratory infections since childhood. no major hospitalization, clear discharge on and off since 5 years of age. He had cervical lymphadenopathy for 2 years before presentation. He was evaluated in multiple hospitals. The biopsy from right cervical lymph node showed Hodgkin's lymphoma. And here I really want this to be thought process or a learning experience, because this is a history I have got from the notes of the hematology team who has seen the child. And at this point of time, if you've had multiple respiratory infection in the past with your discharge and on and off, is it just Hodgkin's lymphoma that you're dealing with? His PET showed nasopharynx mass with cervical axillary gastrohepatic iliac inguinal lymph nodes with a marrow and liver uninvolved. He was considered as Hodgkin lymphoma stage 3. Given OEPA post 2 cycles, the score was 4. And then he got 4 cycles of COPDAC and he got rebiopsy, where he was found to have chronic EBV infection. And at this time, he was referred to the immunology team at Wadia. It's important that malignancy risk associated with these undiagnosed patients who have not had severe enough infections to come to the light of a specialist should be remembered, because this is an excellent paper by Reeve where she's tried to look at what happens in these patients in terms of malignancy. And the onset of malignancy can be between 6 to 40 years, but importantly, the cumulative risk of lymphoid malignancy is very, very high in PI3 kinase deficiency, which is what this child was found to have. I'm going to end here because I'm sure Dr. Mukesh Desai will have a few points to say over this. So, thank you.
Thank you, Dr. Ambreen. Dissecting out the blood picture and trying to connect it to the immunodeficiencies. Mukesh sir, your insights on clinical patterns of immunodeficiency and comments on the current talk.
Well, thank you. It was a lovely presentation, a very clear-cut guideline given by Amreen, and it just tells you that you need to look beyond the immediate diagnosis. So all the three cell line affection can happen with inborn error of immune deficiency and can be their primary presentation. Any combination of autoimmunity or cytopenia with infection, with autoinflammation or immune dysregulation, EBV especially can be a very big indicator to tell you that to look for underlying inborn error of immune deficiency. In fact, I believe that Hodgkin lymphoma may be a primary immunodeficiency disorder and not a malignancy itself. And we have now more than 120 cases where we have seen the classical evolution takes place from primary infection to immune dysregulation to chronic active phase and then progressing to something which behaves like a malignancy, whether there is clonality or no clonality, and whether you want to call it malignant or not malignant, but the behavior is like that of malignancy. So I think very well covered. The age is also very important. Some of the thrombocytopenias, autoimmune hemolytic anemia coming in infancy would be a very important clue to suspect primary immunodeficiency. So I think with this, I'll hand over to Revati to give her comment.
Revati ma'am, your thoughts about early diagnosis and raising the suspicion, educating the pediatrics as a whole.
I think Amreen covered it beautifully, and it struck me when we went to a meeting where they had transplant outcomes in severe combined immune deficiency presented from North America and from Asia. And there was such a big difference because of newborn screening. And they had 100% survival after transplant. And I think the more delays, the more they get more and more challenging, and the cure rates come down or they survive with morbidity. So over the past 2 decades, I think ISPID and PHO chapter have done amazing work to raise awareness. So it is being recognized, and we are seeing early diagnosis now. So hopefully with the whole genome, whole exome sequencing era, things would be better for the next generation to come.
Okay, thank you, ma'am. Thanks a lot. So, moving ahead, I invite Professor Amit Rawat sir to walk us through the next talk, that is laboratory diagnosis, how to make it simple, and what tests to be ordered, and how to come and clinch the diagnosis. Over to you, sir. Amit sir, we are not hearing you. Your slides are visible.
Am I audible now?
Yes, yes, sir. Yeah.
Okay. And my slides are visible?
Yes.
So thank you, Vinay. I would be talking about the laboratory approach to diagnosis of inborn errors of immunity. And I will try to see how much I can cover in 15 minutes. So this is the broad overview of what I will be talking about. I would mainly delve into the diagnostic approach. So inborn errors of immunity is not one disease, but a conglomerate of diseases. There are now more than 500 of these. And thanks to the high throughput sequencing technology, since the 2000, late 2000s, there has been an exponential increase in the number of IEIs which have been described. And even between 2 years, that is 2022 and 2024, as you can see in the bar graph on the right, that even in the 2 years, there have been 63 defects across different categories, which have been described in 2 years. And this has been mainly to the increased recognition of these disorders and also to the availability of high throughput sequencing and technologies which are available to diagnose these disorders. So this is a very useful resource for anyone who is new to the field. This is there is a classification committee. There's an expert committee which meets every 2 years to classify these disorders. And the last such update was in 2024, and this is published in Journal of Human Immunity. And this is a freely downloadable article. So it's a very useful resource for people who want to know more about these disorders. And this is another approach is the phenotypic classification, where there are algorithms for diagnostic, and both these are very useful resources for trainees. So in terms of identifying IEI, I mean, clinically, there are three handles: the age at onset, the type of organism, and family history. The age at onset is important because antibody deficiency, as you know, will not present in the first 6 to 8 months of life, because the maternally transferred immunoglobulins will protect the infant. The type of organisms also indicate the broad category of disorders which are affected. For example, encapsulated bacteria would be more common in complement and antibody deficiencies. Opportunistic infections would be more important in combined immune defects like severe combined immunodeficiency. And then infections with Staph aureus or fungal infections would be very common in phagocytic defects. The family history is also important, because if you have a history of a sibling or any other family member affected, it's a red flag. And you know that you have to screen any infant then who presents in that family. And there are also like different ways in which these disorders are inherited. So a lot of these disorders may have an X-linked inheritance, which will mainly affect males or boys. But you could also have autosomal recessive and autosomal dominant patterns. And increasingly, what is being recognized is also the somatic variants or the somatic mutations, which can also lead to different IEIs. So this table here shows the underlying landscape of infections, which you can see in different defects. So in a predominant T cell defect or a combined defect, you could have infections with bacteria, viruses, parasites, fungi, and mycobacteria, also opportunistic infections. In a predominantly antibody deficiency affecting B lymphocytes, the infections are mainly because of encapsulated bacteria or enteroviruses. In NK cells, it's mainly viruses, but NK cell defects also predispose individuals to tumors. Bacterial infections and fungal infections are seen in defects of phagocytes like the neutrophils and the polymorphonucleus cells. Complement defects like the antibody deficiency present, especially the early complement defects present with infections with encapsulated bacteria. And when you have defects in the mononuclear cells, mainly in the innate and intrinsic pathway, you would have infections with bacteria, fungi, or mycobacteria. And there is a reciprocal relationship between microbial virulence and PID. So if infections occur in due to a non-virulent strain of a pathogen, for example, we have a lot of patients with IEIs who have disseminated infections because of, for example, BCG or because of other OPV. So then the index of suspicion for underlying IEI or PID should be very high. And as has been highlighted in Dr. Amreen's talk earlier, the phenotypic presentation of these IIs is quite varies. So it is not only an infection predominant phenotype. You would have a significant number of patients who would present with autoimmunity either alone or in association with infections, or you could have autoinflammations and also malignancy. And increasingly, there's a group of disorders known as primary atopic disorders, where the predominant manifestation is are atopy or allergic manifestations. So this is the broad category of disorders in the IUIS 2025 update. This has been broadly classified into 10 categories. I think you can go through this paper in more detail. And in terms of a laboratory approach, so there should be a tiered approach for laboratory testing for inborn errors of immunity. And in the first step, the most important thing would be a complete blood count with a differential count, where you would look at the leukocyte count, the absolute lymphocyte count, the eosinophil count, and also the platelet count, and also the size of the platelets. In terms of in the second tier of investigations, you could move on to the lymphocyte subset analysis, where you can look at the T, B, and NK subsets, and also the subsets of T cells, and also more detailed, where you can look at the B cell immunophenotyping at the memory naive B cells. And another important test in this would be oxidative burst by flow cytometry to look at the NADPH oxidase activity for chronic granulomatous disease. Next, you could move on to the enzyme estimation as has been highlighted, the ADA1 and ADA2, or the PNP, a complement function testing, CH50 for the classical pathway, AH50 for the alternative pathway, and you can look at the cell surface and intracellular molecules. And then finally, you could move to the genetic testing, either by Sanger or gene panel, or increasingly, most patients now undergo exome sequencing as the first genetic test for the underlying IEI. And this has also been enumerated in the 4-stage testing by the Jeffrey Model Foundation, where they have indicated the different tiered based approach for diagnosing IEIs. So increasingly, with the wide availability of genetic sequencing, some patients might come first with a gene report. You would be lucky if it is a likely pathogenic or a pathogenic variant, or even if it is a benign or a likely benign. But when we are stuck with variants of undetermined significance, what help would be flow cytometry, especially functional assays to determine the pathogenicity of variants. And then you could do flow cytometry studies, cytokine and cytokine receptor studies. And also like the complete blood count, differential count, and even simple tests like immunoglobulins and NBT would be useful when you have a variant of undetermined significance. Or the other way around, where you don't have the other approach is that you could go with the traditional approach of doing a CBC or the tiered approach I have highlighted earlier. But both these approaches are widely encountered now in clinical practice. So in terms of the armamentarium to diagnose these disorders, you could have nephrometry, a semi-automated and automated nephrometer to measure immunoglobulins, IgG, A, M, E, or the subclasses, the IgG subclasses. Moving on, you could do a flow cytometry, a basic TB/NK panel, or the other subsets. And then you can measure the cytokine by using bead arrays. And finally, you could move on to the genetic diagnosis by Sanger sequencing or next generation sequencing. But simple tests are important. So as you can see by the panel of photographs here, this was a child with Shinya-Higashi syndrome, where you can see these large granules in the neutrophils, and this has been highlighted in the myeloperoxidase stain on the right side. And in the lower panel, you can see a small platelet in a child with Wiskott-Aldrich syndrome. And then this was the last panel shows a child with WHIM syndrome, where there was myelocataxis, which was demonstrated in the marrow. We encountered this case in a few years back. The child presented with what a cyclical pattern of neutropenia. But when the child was investigated, he was found to, actually, there were two siblings, a brother and sister, and they were found to have a specific granule deficiency type 1. And the characteristic on the peripheral smear is that the neutrophils are hypolobated, they are hypogranular, and a careful examination of the peripheral smear is very important in patients who present with neutropenia, so that you can pick up these defects. Marrow examination, this was a child with the ELANE mutation, where there was a arrest of maturation at the pro-myelocyte stage. The dysplastic megakaryocytes can be seen in germline Gata defects, where you have hypolibated megakaryocytes, which have been highlighted by the CD61 stain here. These are mainly in the megakaryocytes, but they can also be seen in the myeloid lineage. And then there's Vexus syndrome, which is caused by a somatic mutation in the X-linked UBA1 gene, where you've got vacuolations in the myeloid and the erythroid precursors. A simple hair examination could also be useful. And this panel of photographs here shows a hair shaft in a child with Shinya-Higashi syndrome, where you can see that the hair shaft is hypopigmented and has got pigment clumps, which are irregularly sized and irregularly spaced. And this one is from Griscelli type 2, which also presents with HLH. And here the hair shafts are hypopigmented, but in the cortex, you can see granules or pigment clumps of different sizes, and they're also irregularly spaced. Coming to the flow cytometry, the flow cytometry is a very useful tool in the evaluation of IEIs. So it helps in the detection of altered lymphocyte populations in different IEIs. It can detect the defect in cell surface expression of proteins, intracellular protein expression. But increasingly, what is more useful, especially when you are stuck with a VUS, is that it can detect functional abnormalities and help you resolve a VUS. And it can be used for evaluating post-transplantation chimerism. And in certain situations where there is a genetic defect has not been picked up, it could also help in doing a prenatal or antenatal diagnosis. So the altered lymphocyte population, how can these be detected? So you can have absent or reduced lymphocytes in severe combined immunodeficiency. You can have absent B lymphocytes in X-linked A-gamma globinemia or autosomal recessive forms of hypogammaglobulinemia. Absence of NK cells can be seen in GATA2 deficiency or MCM2 deficiency. And then you can have absence of monocytes also in GATA2 defect. Evaluation of cell surface proteins. So for T cells, you could have common gamma chain defect in SCID, X-linked form of SCID, or you could have rare forms of SCID where the different the subchains, the CD, zeta, the epsilon, those chains could be absent. Or you could have MSC class 1 and class 2 defect, which can be picked up by flow cytometry. B cells, CD40 defect can be picked up by flow cytometry. CD40 defect can also be picked up by flow cytometry. And FN gamma R1 defect, which leads to MSMD, can also be detected by flow cytometry. These are all cell surface molecules which are expressed on the surface of different forms of immune cells. Flow cytometry can also be used to detect the presence or absence or reduce expression of intracellular proteins. For example, BTK is a protein which is defective in X-linked A-gamma globulinemia. In Wiskott-Aldrich syndrome, both in XLT and VAS, you could have it could evaluate for the intracellular VAS protein expression. For X-linked lymphoproliferative syndrome, you could look at the expression of SAP and XAP. in cells, and perforin in the most common form of hemophagocytic lymphohistiocytosis. Or you could look at FOXP3 in IPEX syndrome. The caveat with this is that the evaluation only tells you about the presence or absence of proteins. So you could have missense variants or hypomorphic variants where the protein is present, but it's functionally inactive. So because this detects only the presence or absence of protein and does not tell you anything about the function of these proteins. So uh, in immune cells, both the number and the function is important, or the quantity and function is important. And this is the caveat with detecting this protein expression. So you could have XLA even with a normal BTK protein expression, because it does not tell you whether that the protein is functional or not. So coming on to the functional test by flow cytometry, you could do a oxidative burst in granulocytes by DHR, which is a very important test for chronic granulomatous disease. You could look at NK cell function by granule release. You could assess TLR signaling or receptor signaling by specific intracellular protein phosphorylation, which are known as the phosphoflow assays. Or you could look at cytokine production by activated T cells. So I just move you through some plots in patients with SCID. So this is a T minus B plus NK minus SCID, where you can see that the lymphocyte on the first plot, the lymphocytes have been gated on CD45 versus side scatter. And then when you look at the different subsets, the CD3 positive T cells and the CD56, 16 positive NK cells are absent. So this is a T minus B plus NK minus SCID. So this is another case of SCID where again the CD45 positive and lymphocytes have been gated. And then again, when you look here, the situation is different. The CD3 and the CD19 are absent, whereas most of the cells in the gated lymphocyte gate are NK cells. So this is a T minus B minus NK plus SCID. You could have a T minus B plus NK plus, where the B cells and NK cells are present, and the only cells which are absent in the peripheral blood are the T cells. Or you could have a very severe lymphopenia, as you can see in ADS SCID, where there are hardly any lymphocytes in the reticular dysgenesis, where there are hardly any lymphocytes. This is actually ADS SCID, because in reticular dysgenesis, you don't even have neutrophils. So there are hardly any few cells. So this is a T minus, B minus, NK minus SCID. Or you could have some situations where T cells are present, but they're abnormal, like in Omenn syndrome or maternal engraftment. So the T cell basically TB NK panel does not only tell you about to confirm a SCID, but it also hints towards the genetic etiology. As you can see here, a T minus, a B plus NK minus could be IL2RG or JAK2. A T minus, B minus, NK plus is most commonly a RAG1 or a RAG2, or it could be a ligase 4 or Artemis. A T minus, B minus, NK minus is usually a ADA or a PNP, and the T minus, B plus, and K plus, where only the T cells are absent, is the most common genetic defects is in the alpha chain of the IL-7 receptor, or it could be the different co-receptors of the CD3, the CD3 delta, the CD3 epsilon, zeta, or it could be because of CD45 defect. And for Omenn syndrome, you could look at the HLA-DR expression on CD3 lymphocytes. So HLA-DR is a MSC class 2 molecule, but it can be expressed on activated T cells. And as you can see here in the lower panel, in the patient with Omenn syndrome, there was a markedly elevated expression of HLA-DR on the T cells compared to the control. Immune dysregulation, this is a case of ALPS, where there was a increased in the double negative T cells, the TCR alpha beta positive, CD3, CD4, CD3 positive, and the CD4, CD8 negative. So this is another case of, this was a child who presented who was given BCG late, but he developed a left axillary BCG adenitis. Excision biopsy showed acid-fast bacilli, ATT was started. He had bilateral sensory neural deafness, and then he was admitted to PGI. He had multifocal osteomyelitis. And upon flow cytometry, there was an increased expression of hyphen gamma R1 on the gated monocytes and lymphocytes, indicating that it was a partial dominant form of hyphen gamma R1 defect. So this is a cartoon which shows the defects in innate and intrinsic immunity and the prototypic disorder is Mendelian susceptibility to mycobacterial diseases. Coming to the genetic diagnosis, the genetic diagnosis is important because it provides a definitive diagnosis, at times resolving a diagnostic odyssey. In that age of sequencing, it also has implications for targeted or personalized medicine, because some of the variants, if you detect in certain specific pathways, you have drugs to target those pathways, and this could be the treatment for the patient, or they could be a bridge until they are transplanted. You could have unusual or atypical phenotypes of known defects, or you could describe new genes for previously described phenotypes. It helps for advocacy of patient. It helps advocacy for patient benefits. Genetic diagnosis are also implications for undiagnosed family members, potentially some who will be carrying the variant but be asymptomatic at that point in time, or they could be carriers for this disease. And so it has implications for genetic counseling, and it is imperative for genetic counseling and antenatal diagnosis, and where available, also pre-implantation genetic diagnosis. So there are different methods of doing genetic sequencing. The classical method, which has been used 2 decades back, is a Sanger sequencing, where individual genes or parts of genes or exons are sequenced one by one. But what has transformed the landscape of rare diseases or genetic diseases is this massively parallel sequencing, where you can sequence thousands of genes together, practically the whole exome of an individual or multiple individuals, or also the whole genome of the individuals very fast. You could also do RNA-seq, which is very useful in disorders of where there are splice defects, where you cannot predict the effect of the splicing based on the gene sequencing. The RNA sequencing could be of use. And increasingly, there are some disorders where, because the important thing to realize is that doing exome is not a solution for every disorder. There could be disorders which are associated with copy number variation, either deletions or duplications, especially large ones, which can be picked up by other techniques like fluorescence in situ hybridization, chromosomal microarray, or multiplex ligation-dependent probe amplification. So this table here shows the different the different levels of testing, and so the gold standard has been Sanger, but there are NGS panels which have got a very high coverage. So the panels have a coverage of a range of 200 to 300x, or for somatic, it could be even higher. For exome, it is in the range of 30 to 100x. For genome, it is 20 to 30x. This Sanger sequencing can detect splice site variants. NGS panel can detect the somatic variants. Whole exome sequencing cannot detect the deep intronic variants because it is focused on coding regions. Whole genome sequencing can detect everything. It is also a bias-free approach, but it's very expensive, and the data analysis of the genomes and exomes is complicated. Large indels are missed in exome sequencing and also could be missed in NGS panels. And the most rapid would be a small gene panel focusing on your phenotype, or a rapid exome. The whole genome sequencing, the data analysis takes a long time. It is more expensive, and the data analysis takes a long time. So realistic turnaround times and clinical setting is not possible. So with that, I would like to end, and thank you so much.
Thank you, Dr. Ahmed, for that simplified approach. As a pediatrician who's sitting in a two-tier city, I think my biggest problem is that I know these tests, so probably with your help now we know how to interpret it. But how do we get the right person or the right lab? So that's something I wanted to ask you. Is there any special lab all these samples have to go to, or these can be interpreted and dealt by any hematopathologist or a pathologist?
I think the basic lymphocyte subset, and am I audible?
Yes, sir. Yeah.
So for the basic lymphocyte subset, I think probably
yes, you are.
Hematologists and hematopathologist who are doing leukemia and lymphomas, I think it should be possible to do even in a medical college. If you have a flow cytometer and you're already using it for a leukemia lymphoma, you can easily adapt that to look at the lymphocyte subsets. I mean, to do a basic TB, NK, or a T cell subset, expanded T cell subset should not be difficult. And the interpretation would be very, especially in cases which are not, I mean, which are typical, like the T cell absence, that should not be difficult.
Yeah.
And even
Thank you, sir. I think
basic
all of
tests
us
like
had
immunoglobulin, flow cytometry, you can at least make I mean, like at least a broad category of disorder, whether it is a combined defect or it is antibody defect. I mean, that you can at least do with simple tests which are available at most centers now, at most medical colleges now. Maybe if you're stuck with a VUS or you have a peculiar kind of a variant.
Thank you. Thank you, Dr. Ahmed. I think you've made this really simple for us. I'm not sure, Dr. Ahmed. I think my internet here is unstable. That's why I thought I lost you in between.
Yeah.
So
Yeah, Dr. Shruti.
I think
So
I would like to thank you for simplifying all for us.
Thank you.
And now we'll move on to Revati ma'am. I think Revati ma'am needs no introduction, and she'll be talking now that you've made a diagnosis, how to manage these. And as ma'am said, there is a huge gap in what happens in the West and what happens in our country. Let's learn the nuances from her, how we can, make outcomes better in our own country. Over to you, ma'am. Thank you.
Thank you to the team at IAPPHO for this opportunity. I know we are running late. I hope you can hear me well and see my slides. Can I continue, please?
Yes, ma'am.
Yeah. So I have about 12 minutes to talk about how, once we've made a diagnosis, how we manage these children. And I just want to spend a few minutes to talk to you about what the scenario was in 2002. And it was very tough because we didn't have any awareness. Now that we have awareness, people are diagnosing them, and the babies came to us quite late, and we had a lot of problems with access to diagnosis. And PGI and Dr. Manisha's team and Dr. Mukesh Desai's team were really the pioneers in telling us about how to make these diagnoses within our country. There was no access to molecular diagnosis, and it was really tough because we had to send these samples abroad and very limited transplant centers. So we used to get patients all the way from CMC, from Ludhiana or from PGI Chandigarh coming down to Tamil Nadu for their transplants in those days. And even physicians themselves had a lot of bias because they thought these are genetic disorders and it was not curable, or the family cannot afford, they're too poor. So things have changed now, and even at that time we did not have access to prenatal because genetic diagnosis molecular was not possible. And to top it all, when things were getting a little bit better, 2012 saw an increase in multi-drug resistant bacteria, and these babies that went from one hospital to another eventually had a lot of resistant bacteria, which is how we lost them. So you can see the outcomes were dismal before 2016, and this is data from our country, where after that things have improved dramatically because we've had meetings to raise awareness. We've had access to gene mutation, high resolution HLA typing, a lot of training technology and sessions such as the one we're conducting right now to talk about transplants. And this is one of the babies we transplanted in the newborn period, and she's now a beautiful 7-year-old girl going to school. So this is all possible within our own country. I just want to talk about stabilizing a baby who's referred to you with severe combined immune deficiency. What we don't realize is there's a lot of BCG, lot of CMV and pneumocystis. And nutrition is the focus, and we have to try and establish good nutrition before we take them up for any transplant or treatment. And very, very simple elemental feed is what is required. Something like Neocate is what we use along with partial TPN. A full TPN usually increases their risk of candida. And IVIG, of course. And if they've come to you too late, somehow these parents are young and they're going to go ahead and have a next baby without counseling. So at least let us store the DNA or send the genetic material and counsel the parents that this is a genetic condition. The non-skid ones are the ones that are really, really challenging because they are a very heterogeneous group. And some of them come with autoimmunity and immune dysregulation. And this is a challenge. Amreen had presented beautifully that the children that present to us with autoimmune features, they have a far more challenging course during any curative therapy than those who present with just recurrent infections. And I'm not even going to mention the ones that come with malignancy. So, a pure infection spectrum or an autoimmune spectrum or a malignancy spectrum, which is rare, but the autoimmunity one is a challenge, especially inflammatory bowel disease. Because remember, all our conditioning chemotherapy is going to hit the gut. If it's already inflamed, it is going to be a challenge, and they have a prolonged and difficult course. But with all of this awareness, we are seeing babies being diagnosed early, getting access to treatment, and getting cured. And even rare disorders like IL-10 Ra, who had this is a baby who never ate in his life because he had inflammatory bowel disease, and after a transplant, is now able to eat normal. And we have newer indications where we've got data from our own country to say X-linked agammaglobulinemia and other disorders, we can transplant them. So this is an exciting time. So I want to go back to 2002 when we did this babies transplant, and we didn't have a gene mutation, and we used a busulfan-based conditioning. He did so well, but after 3, 4 years, he had busulfan-induced lung fibrosis because he had a DNA repair defects type skid. So this is something we wouldn't do at this point. So choosing our patients wisely and how to condition them is all based on a genetic diagnosis. This is a baby we transplanted with ALL and SCID. She's doing really well. So we only had access to sibling donor at that time, but now we have matched unrelated donors and haploidentical. With the haploidentical, with these babies with comorbidity, we have to decide which one to choose. Are we going to use TCR alpha beta or a PTCY? Because it's tempting to use the PTCY platform because cyclophosphamide is not as expensive as TCR alpha beta, but when we have looked at it, there is a lot of viral reactivation with TCR alpha beta, but there is organ dysfunction when we use PTCY platform. So recently for these IEI children, we have moved to a TCR alpha beta platform where we are adding memory cells. And this outcome has really improved our survival and TCR alpha beta depleted grafts just in this immune deficiency group. It scores over the PTCY platform. And conditioning, we know that they need reduced intensity conditioning, but some of them need myeloablative, but most of them reduced conditioning. And after we've had triosulfan introduced in our country, things have been better. These babies come with vaccine induced complications. We have to be mindful of BCG, especially, which has been a problem. And we have to support them for 2 weeks when they are neutropenic. And I told you about the multi-drug resistant bacteria, which has increased from 2012. So the perianal area in these babies is especially sensitive. So we have to make sure that we have some trophic feeds and good perianal care. This is specific for the immune deficiency babies. And when we use triosulfan in them, the skin is very sensitive and we need to protect the skin. Cytokine release syndrome is a big problem and challenge because if we flood them with steroids and anakinra or tocilizumab, we will have infections thereafter. So this is something we have to watch in these babies. This is a baby we transplanted with MHC class 2 defect. And after 100% donor, his bowels never moved after engraftment, but everything was aspergillus. CMV is a big problem in all of our patients, and especially after we started doing haplos. You can see the graph is almost more than 70% of patients have viral reactivation. But after we've had letermovir for the past almost since April of this year, the incidence of CMV related mortality in this group has come down dramatically. Do these children need 100% donor cells? No. So they are very different to the leukemic. So we don't need to push. And we've gotten better and better at looking at the chimerism and split chimerism in these babies. And some of them, like HLH, need only 30% chimerism. But what they don't need is graft versus host disease. It was in the range of 40% in our patients and the cause of death in 12%. So we need to have avenues where we don't give them GVHD. And what we need to watch is after they've had a transplant, how is their immune system reconstituting? This is a CGD baby that we transplanted, and he never had immune reconstitution. You can see how wasted he is. But another skid baby that we transplanted had good immune reconstitution, and you can see that they eat better and weight gain. So, simple clues like weight gain will tell that the transplant has worked. We not only need to transplant them, but also watch for late effects. So, we have now 20-year data which says that the triosulfan children do better than busulfan in this cohort because there's no reduction in their final height or impact on their puberty. So at our center, we've got 74% outcomes. You can see that the kids are not as great as the other conditions because they come with a lot of infections. And this is one slide that I particularly like because we went back and looked at our first 100 transplant versus the second 100 transplants, and the outcomes were far, far better compared to the ones we did initially with all the facilities available now. Like I said, high resolution HLA typing, gene diagnosis, targeted, tailored conditioning. And we are working together with all the centers through the ISBMT platform, and things are better. Our matched donor transplants are doing so much better. Haplo and MUD, we need to work on alternate donor transplant to do far more work on this in this avenue. We've got a lot of funding. I think we should talk about this in one of our PHO chapter meetings because all of us can look at protocols. We know what to do. We can talk to each other, but how do we do the funding for these individual children? The future for the IEI children, I feel, is bright because hopefully we will get gene therapy like the Tata group has done with IIT Mumbai, have our own indigenous CAR T like that, our own gene therapy. I know groups are working in our country, and many wishes to them to come with a good solution early because with gene therapy, we can have better outcomes. Thank you so much for the opportunity.
Thank you, ma'am. Ma'am, just a quick question. You said you're scared of. So, do you use a capping, stem cell CD 34 dose, or how do you go
So,
about?
yeah, so everything depends on whether we are dealing with a sibling allograft, a MUD, or a haplo, and also whether we are using bone marrow or PBSC. So with the bone marrow, we know that if I used a triosulfan protocol, then mixed chimerism is a problem. So especially with the babies between day 90 and day 120, they have a lot of mixed chimerism, and in this group, mixed chimerism can lead to autoimmunity. So, with the babies and a RIC protocol, we would go for a higher CD34 dose, like 7 to 8 million cells per kg. If it is TCR alpha beta depleted, aim for 10 million cells per kg because you can go higher because it's a depleted graph. With MUDs, we try not to go more than 5 million cells because the higher number of CD34, means a higher number of T cells and therefore more GVHD.
Right. And ma'am, one last question before we go on to the cases for you and Dr. Mukesh. The rare disease policy which came in. So if you can highlight that, how can that help these children, but we were just talking of funding and raising funds. So is there something that the rare disease policy can help in such scenario?
I think Dr. Mukesh will be a better person to talk about it because we work in a pure private setup and getting funding is a big challenge. But if you are in a public-private partnership setting or a setup or a trust hospital, then there's more access to funding. Dr. Mukesh, would you like to highlight on the rare disease funding, please? I don't know. Yeah. So,
I
as far as I know, Coal India funding we can have access to, and we can have the rare disease policy. If you're in the centers of excellence, a family can avail of up to 55 lakhs. But you have to be at the moment in the 12 centers of excellence or have an MOU with one of the 12 centers of excellence. So, any public or private hospital, if they have an MOU with the center of excellence, then the family has access to funding. I think we all have to work together and make sure that there is more awareness created about funding so that each family can have a curative option closer to their home rather than travel and be away from home and struggle for that.
Vinay, would you like to take over now?
Yeah. Okay. Thank you, ma'am. Very inspiring talk. Mostly photos, and we know that each child will have its own story and the struggle behind the medical teams. So moving forward, I would invite Ajita to conduct a panel discussion with two amazing cases. Over to you, Ajita.
So thank you, Vinay. I hope everyone can hear me. So I thank IAP PHO chapter for giving me the opportunity to discuss the cases and to put questions to stalwarts in their areas. So I'll move on to the case one. So this is a baby who presented at 4 months of age to us, second born to non-consanguineous parents, received birth dose BCG OPV as well as the 6, 10 and 14 weeks of vaccinations. He was admitted elsewhere with sepsis and meningitis in the newborn period, and blood cultures as well as cultures from the CSF were sterile. PCR panel was negative. It was a lymphocyte predominant CSF in the cell count, and MRI did reveal meningitis picture. Echo was normal, and somehow there was a thought of immunodeficiency because the ALC was low. It was 1200, which was low for infancy, and they had done a CD4 and 8 and not a complete lymphocyte subsets. And they had said to the parents that the child is probably having an immunodeficiency and kept on follow but not evaluated. When he presented to us, he had recurrent diarrhea and vomiting, and he was received in severe hypovolemic shock, metabolic acidosis, lot of fluids, bicarb correction, and stool PCR was positive for rotavirus, and rest of the infective workup negative, and CMV PCR blood was negative. And complete blood counts done at our hospital revealed a normal ALC and ANC. ALC was 3,500 here. Question to Dr. Professor Desai. So what is the, so I know we are looking at early onset immunodeficiency and probably a SCID, but what will be the cutoff of ALC in this case? And when can we have a normal ALC even when there is a SCID? And how do we evaluate further?
Well, thank you for the question. I think this child clinically definitely looks like an immune deficient child. He has two very severe episodes of infection. Currently, we believe that any child who lands up into a PICU probably is an immune deficient child. If you see the previous report, the child had a low ALC, and children are largely lymphoid organs, and their absolute lymphocyte count is much higher. So an absolute lymphocyte count of less than 3,000 in an infant would be considered as a lymphopenia. But I think there are situations where you may have a normal lymphocyte count in a child who is having features which looks like severe combined immunodeficiency, probably because of maternally transmitted lymphocytes, which the immune deficient child is not able to remove. The other possibility is that if you have an Omen syndrome or a leaky skin, then you can have an absolute lymphocyte count which can be normal. And you in MSC class 2 deficiency, you would have a normal absolute lymphocyte count. So these are some of the situations where you can have a normal lymphocyte, but the clinical scenario should tell you that you need to probe further and look for the lymphocyte subset to see if a specific subset is abnormal or not.
So then we went ahead with the basic lymphocyte subsets which we have here, and it revealed low T cells, as we can see, both the absolute and the percentage, low NK cell and the normal B cells. I'm sorry I don't have the flow plots, but I think Dr. Rawat had already discussed on flow plots in SCID. So I would like sir to comment on what would be the further functional tests available in SCID based on the flow and the possible mutations in this particular case. And is it possible to differentiate maternal T cell engraftment based on flow?
So so here you can see that in the peripheral blood lymphocyte analysis, the most of the cells, 96% of the cells are B cells. There are hardly any T cells, like 2.5%, and there are hardly any NK cells. So it is a T minus B plus NK minus kit. And going by the genetic, the table, the figure I showed you, it would be probably either a IL-2 RG X-linked skid or a JAK3 mutation. These are the common ones which present with a T minus, B plus, NK minus phenotype. Having said that, there could be alterations as well, but most commonly, a T minus, B plus, NK minus would be because of either a IL-2 RG, which is X-linked, or because of a JAK3. So the functional test for the IL-2 RG, you could look at CD132, which is the common gamma chain, or you could look at the phosphorylated pStat1. You could stimulate your whole blood or your sorted your PBMC with either IL-2 or IL-21, and then look at the phosphorylation of STAT5, which is downstream of both IL-2 RG and JAK3. So these are the functional tests you can do in this kind of scenario. And in addition, you could also look at the naive and the memory cells. So as you can see here, there are hardly any naive cells. Most of the cells are actually memory cells, memory or effector cells here.
So this was so the problem with us is we don't have functional tests readily available nearer to us. We had to send to either PG or NIH. So this was done at NIH and shared to us by Dr. Umair. Sir, can you comment on the CD132 flow, because for us functional tests are not easy to understand.
So I'm not sure why this was done on T cells like CD132, because there are hardly any T cells in the child. The T cells are only 2%. So in this situation, you would either do it on a B cells, which also express, or on the monocytes. But having said that, even a normal expression of CD132 does not rule out IL-2 RG mutation. Because as I said, it's not a functional test. It's just tell you whether that protein is present or absent. It doesn't tell you whether that protein is functional or not. Especially it has been seen that the mutations which occur in the cytoplasmic domain of the IL-2 RG, they can be associated with a normal or not markedly reduced expression of CD132. So normal CD132 expression on like the B cells or monocyte does not rule out IL-2 RG skip. What would be more important is to look at stimulate the cells, the PBMCs with IL-2 or IL-21, and then look at downstream pStat5. If that is reduced, then you can be more sure that this is probably either a IL-2 RG or a JAK3. Or if you have a VUS and then you want to look at the functional effect of the VUS, that this test would again be useful.
So how long is it okay for the transport delay, sir, if we need to send it to NIH or PG?
Like for the functional tests, it has to be 24 hours. I mean, like you can't do more than that because you are stimulating the cells and dead cells will not respond to stimulation. That is a problem.
Thank you, sir. So for this child, we did further workup to rule out active BCG infection because many children do have BCGosis. And all the workup was negative. The child had another episode of diarrhea meanwhile. Blood cultures revealed non-typhoid salmonella and treated with cefotaxime. And I would like to ask Professor Desai to comment on the workup for infections and diarrhea in this child, and what to do if the child has BCG infection, and if not, what is the prophylaxis and skip, considering that we'll need to proceed with a transplant.
So the job of a pediatrician who is seeing or a specialist who is seeing this child probably to prepare for transplantation, since you are very strongly suspecting and you have almost confirmed the possibility of an IL-2RG deficiency in this child. So what we do at Warrior Children is that all these children, we evaluate for infection. And the infection which we commonly look for is that CMV, EBV, and parvovirus. So CMV is, we give them CMV prophylaxis, we give them PCP prophylaxis. At any, say for diarrhea, if the child has received rotavirus, we would vaccination. We would even try to see if there is not a rotavirus-induced, vaccine virus-induced diarrhea. We would give this child IV gamma globulin. We would do biofire for in the stool to see if we can pick up any organism. Cryptosporidium is another thing which we would look for. In the blood, a multiplex RT-PCR, a sepsis panel to look for any fungi. So these patients also receive antifungal cover with either fluconazole or miconazole. We give them ganciclovir as a CMV prophylaxis. For children who receive BCG, as in this case, we would give them two drug AKT, or if they have DCGOsis, we would give them 3 drug AKT, and send them, hand them over to the transplant team. If you control the infection better, their outcome would be better. So we go all out to identify the infection and give them all the prophylaxis which is possible, including IEIG also.
Thank you, sir. So one point we did realize was rifampicin has a lot of interactions, so we generally try to switch it with quinolones or other drugs. And this was the diagnosis we got. We had specifically asked the lab to look for the phenotype of T minus B plus NK minus KIT, look for interleukin 2 RG mutation. But what we got was surprisingly mutation for monocarboxylate transport deficiency, which is associated with metabolic acidosis, as was seen in our case. Severe disproportionate acidosis in response to infection. And there was another variant of uncertain significance, which was RPA1 gene mutation, both of which did not fit with the phenotype in our case. And we specifically again requested the lab to cover the particular genes. And what we got was there were no, the genes were okay, and it was not affected. So what do we do in such situations? So we did get an expert help, and Dr. Rawat, how often do you see mutations being missed when there is a particular phenotype, and how do we proceed further?
So copy number variants, like as has been highlighted, especially large deletions, if you are not aware, they can be missed. So if you're very sure of the phenotype, you should ask whether that gene has been covered fully. What is the coverage of that gene? So by coverage, you mean that how much of that coding region of that gene has been covered. So, I mean, the labs do give a detailed report, or they give it as a PDF where each gene of your gene of interest, what is the coverage would be defined. So if there's a large deletion, there would be no reads from those particular exons.
So this is what we got. The gene coverage was not 100% for interleukin 2 RG. And we got the raw data, got it analyzed, and indeed there was a deletion, as you suggested, in the IL-2RG gene. And probably this can be confirmed with other methodology apart from sequencing. But since we got an answer now, we proceeded with the transplant. And there was no matched sibling or unrelated donor. The child underwent a half-matched transplant. And I think Dr. Revati is an expert. She has already shown us a lot of cases. So what would be your strategy here, ma'am, for SCID and post-transplant precautions specifically here?
So, yeah, I mean, this is quite challenging because you got holy lungs. So this is difficult to take up. And a lot of these babies, we actually put them on high flow oxygen, and because just the work of breathing makes sure that they don't put on weight. So conditioning regimen will be reduced toxicity 1 with fludarabine, triosulfan, rabbit ATG, and would you do an unconditioned skid? So we are moving away from unconditioned skid these days because when their immune system comes back, their B cells are not that great. So the T cells and B cells don't talk to each other. And recently, when I went for the inborn errors EPMT meeting, they have been reporting a peculiar IgG virus in the liver in the second decade in all of these children who did not have any conditioning and went through transplant. So previously we thought T neg, B pos, NK negative, if you do without conditioning, they should be okay because the donor's T cells will work with the recipient's B cells and the donor T cells would work together, but they do have long-term complications. So if you want good immune reconstitution, use some conditioning is the way we are thinking these days. And the memory cell add back and letter movate definitely will help in these children to prevent reactivation. Some of these patients who have refractory CMV, in our own country, we now have CMV specific T cells also that we can give. So a lot of advances have happened in the CMV world in our own country.
Thank you, ma'am. I think for this child, I got your opinion too. So we proceeded with the transplant, and the child got a severe PCP post-transplant. Thankfully, recovered from it, and he also did have a right fungal otitis media, and we gave him amphotericin, and he improved. The issue now is post-engraftment. He developed. He was doing okay, but then day plus 41, he developed fever with rash, pedal edema about 3 weeks after starting Cetran, and all his infective workup was negative, except for an ultrasound which revealed small hypoechoic lesions in the spleen. And so we thought probably it was a dress syndrome. There was eosinophilia, progressive eosinophilia. We stopped Cetran and added steroids. But then he's been having this fever and rash on and off whenever we try to taper immunosuppression, and all the infective workup, including viral workup, has been negative so far. The baby is always well and active. Even today, he's been admitted with fever and skin rashes, which sort of look like a maculopapular, sometimes urticarial rash. So, and there is some mild swelling in the BCG site, not enough to cause an abscess. Dr. Amrin, what will be the differential diagnosis in this case? And how common is iris post-transplant and skid? And how do we proceed with the immunosuppression?
So what I would say is that I wouldn't have preferred giving steroids. The lymphocyte recovery here is very, very crucial. You are looking at a child we've transplanted for the purpose to give him new lymphocytes. So in that scenario, probably figuring out what it is, because the child is well, figuring out what it is should be more crucial than starting therapy. What we would do in the scenario when we don't know what we're looking at is do a skin biopsy. It's a very simple procedure. It's done an outpatient. Your dermat team can come and help you out with. But if you're saying that there is not enough BCG site swelling, there's no lymphadenopathy, there is no other way to tell us that this is BCG, then I would not really be sure that this is BCG iris. Now, iris fundamentally means that a lymphocyte recovery is causing a response. So wherever there is an infection in a SCID patient pre-transplant, you have a risk of getting iris there post-transplant. So iris is common, iris can happen. Do all of them get iris with all of the infections? No. But as a thought process, when you're starting off with transplanting them, we would ideally think these are all my principal infections I'm going in with. And which of these would probably be one in which I can get iris as a post-transplant complication. But an unexplained skin rash where I cannot pinpoint and identify what it is, I would want to do a biopsy.
Thank you, ma'am. So we do have the immune reconstitution reports with T cell recovery. And a basic question to Dr. Aitri, what will be the precautions for sibling vaccination in children's care? And when do we vaccinate the index child?
So, vaccination for the index child in IEIs alone, it takes a long time. So, the skid babies, we look at the TNB markers and then look at the CD4 counts and then because they'll be on IVIG replacement sometimes even for a year or longer. So, we have to wait for immune reconstitution, make sure we have at least CD4 of above 400 before we withdraw the BCG treatment. And for the sibling, we definitely tell not to do oral polio drops or MMR live vaccine. We've had vaccine-induced poliomyelitis in our skid baby during transplant because we didn't check before, but nowadays we have the enteroviral panel and the national surveillance for polio. So, vaccine polio, we are able to diagnose and at least treat these days. So, I mean, know about it these days. But definitely, oral polio and measles avoid in the sibling.
Thank you, ma'am. So, for want of time, I'll just skip to only this last question to Dr. Desai. So, this child had a RPA1 gene mutation, which is an autosomal dominant condition, which is associated with bone marrow failure and late onset pulmonary fibrosis. We have sent the Sanger sequencing for both the parents. This is associated with telomere shortening, but we don't have the baby sample now. Is it possible that the baby may have a significant mutation, and is it possible to do a telomere length in both the parents after Sanger to check whether it is a significant mutation? To Dr. Amit.
Did you get back the Sanger segregation? Like, does one of the parents have the same variant?
We are awaiting the report, sir.
No, you can wait for that. I mean, like doing a testing in the parents, and I don't know whether, like, if neither of them is one of them is a carrier for that particular variant, and or he or she doesn't have any symptoms, I think probably the variant would not be that significant.
Thank you, sir. So I think I'll stop with the first case for want of time. I again thank PHO for the opportunity, and over to Vinay.
Thank you, Ajita. Thank you for an amazing case, and thanks for all the discussions. Manas sir, any announcements before we end the session?
Yeah, just one quick announcement that, this is International Childhood Cancer Awareness Month, and we are going to have a special session by Professor Rob Peters, whom you all know is going to be the next SIOP president. And he's going to speak to us on childhood ALL. And this is a special session. And because of the timing issue, we are going to have it at 4:30 p.m. on 25th of September. And you'll get an information about this very soon on your email.
Thank you, sir. Thank you. So with that, we'll conclude the session. So we thank all the participants who have stayed longer to listen to the experts. And most importantly, thank you for expert faculty who have joined and given their insights. Thanks to the IPPHO chapter for helping us arrange these sessions. So we'll see you on the international webinar session. Thank you.
Thanks to ECHO as well, our sessions are becoming longer and longer. Thank you, Manisha.
Thank you. Thank you all.
Welcome.
Good night, everyone.